And I want alert mind here. In classification of surgical wounds, we have class 1 wound, we have class 2 wound, class 3 and class 4 also. Class 1 wound is also called clean wound. Class 2 wound is called clean contaminated wound. Class 3 is called contaminated wound. And class 4 is dirty wound. Class 1 is clean. Class 2 is clean contaminated. Class 3 is contaminated. And class 4 is a dirty wound. Now, what is clean? What is clean contaminated? What is contaminated and what is dirty is important. It is called a clean wound. Just write down this definition. I'll make you understand this. Class 1 wound is one where the wound is exposed to only skin microorganisms. When the wound is exposed to only skin microorganisms in controlled environment. Class 1 wound is one where the wound is exposed to only skin microorganisms in controlled environment. Class 2 wound is when the wound is exposed to not only skin but also GI tract, respiratory tract, or urinary tract organisms in controlled environment. When the wound is exposed to not only skin but also GI tract, respiratory tract, or urinary tract organisms in controlled environment. Contaminated wound is one where the wound is exposed to any organism in uncontrolled environment. Contaminated wound is one when the wound is exposed to any organism in uncontrolled environment. Dirty wound is when a contaminated wound is left alone for more than 4 hours. When a contaminated wound is left alone for more than 4 hours, or when there is a gross spillage of infected when there is a gross spillage of infected material on wound, it is called dirty wound. Then the wound will be considered as a dirty wound. Okay. Now let's understand this. This understanding is a key. Everyone sitting here should get this understanding, and this is a very commonly checked question also in our exam, where they will give you a particular wound and they will ask you what type of wound is this, or they can ask you what will you do in this kind of a wound. What we will do in this particular wound, we will decide subsequently, but first we have to know what type of wound we have. Now, first of all, what we need to see here, very important, all of you stop writing and try to understand. In class 1 and class 2 wound, the environment mentioned is controlled. In class 3 and class 4, the environment is uncontrolled. Agreed? Agreed? So, in deciding any particular wound, in any given question, listen to this very carefully. This understanding is the key. Otherwise, you will not be able to make out the answer. We have to look at two things. In deciding a particular wound, what type of wound are we going to have in a particular scenario depends on two things. One is the environment the wound is going to get exposed to. Second is the organism involved. Environment can be controlled, environment can be uncontrolled. Now, what makes environment? We have to first understand that. The two things makes environment. What are those two things? Outside environment and patient's own environment. Two things are going to make environment. Outside environment and patient's own environment. What does that mean? Say, for example, I give you example, then only you'll understand. In deciding any wound, we have to look at two things, organism and the environment. So let's see. Imagine if I ask you, what type of wound are you going to have in sebaceous cyst excision? What type of wound are we going to have in a sebaceous cyst excision? So that means I have to look at two things first, environment and the organism. Environment is itself constituted by two things, outside environment and patient's own environment. So let's understand this environment here. Outside environment. Where are you going to operate sebaceous cyst? You are not going to operate sebaceous cyst on the road. You will operate in the minor operating room. And minor operating room, we keep sterilizing. So that means outside environment is controlled. Right? So one of the factor in environment is control. Now we have to see patient's environment. Sebaceous cyst is a pathology arising from the skin appendages. There is no infective foci in this. So that means patient's own environment is also controlled. So that means environment is controlled. So that means this wound can either be clean or clean contaminated, because it can't be contaminated or dirty. Now we have to see the organism. Sebaceous cyst is a pathology arising from the skin appendages. So that means the organism it is going to get exposed to is only skin organism. So what type of wound will it be? Clean wound. The same surgery can have a different wound also. How? Say for example, if I ask you what type of wound are you going to have in an infected sebaceous cyst excision? Infected sebaceous. Again, don't be in hurry. Don't be in hurry. We have to see the environment. We are going to again operate in minor operating room. Outside environment still controlled. Infected sebaceous cyst. This time, patient's own environment is not controlled. So it can't be a clean or it can't be a clean contaminated wound. It is either contaminated or it is dirty. Right? So out of contaminated and dirty, what will it be? Contaminated. Because there is not going to be gross spillage of organism going to happen, and neither you are going to leave this wound open for more than 4 hours. So it is a contaminated wound. Understood? Similarly, if I ask you, what type of wound are you going to have in cholecystectomy for cholelithiasis? Cholecystectomy for cholelithiasis. Again, we have to see two things: environment and the organism. Where are you going to operate cholecystectomy? In the elective operating room. Outside environment, cholelithiasis. There is no infective foci in cholelithiasis. So patient's own environment is also controlled. Now you have to see the organism. You will give incision on the skin to remove gallbladder. You have to give incision on the skin, muscle, peritoneum. The organism getting exposed at this moment to the wound is only skin organism. Then you will divide cystic duct and cystic artery. To remove gallbladder, you have to divide cystic duct and cystic artery. So, moment you divide cystic duct, your Caesar has a GI organism released, and if this Caesar touches the wound is getting exposed to not only skin but also GI tract organism. So environment is controlled. So what type of wound it will be? Agreed? All of you? Now, same surgery again can have a different wound. How? Say for example, if I ask you, what type of wound are you going to have in a cholecystectomy for empyema gallbladder? Empyema gallbladder is a pus inside the gallbladder. So environment from patient side is uncontrolled, right? So now when I do cholecystectomy, uncontrolled environment, any organism, it will be contaminated. But imagine while doing a cholecystectomy for empyema gallbladder, just think about it. Inadvertently, by mistake, my Caesar touches gallbladder and gallbladder ruptures. Now there is going to be a gross spillage of an infected material now. So this surgery now will be, so this will be dirty now. So that means no surgery can be confirmatively say that it is clean, contaminated or dirty or contaminated. It depends on the environment and the organism. Now, if you have understood this, whatever question I should ask now, you should be able to answer. So let's see. Let's see. What type of wound? जल्दबाजी नहीं है, दिमाग लगा के करना है, रट्टा नहीं लगवाता मैं. You are seeing here that I am not one of those who talk about all those rote memory things. I talk about concepts. Tell me, what type of wound are you going to have in a MRM for carcinoma breast? See, I teach with this intent that after my class, my students should start applying mind. There are few things we have to remember, but then surgery is not about remembering, it is all also about concept. सोच के बोलो. Clean contaminate. Clean contaminated. Okay, let's see the environment. Where are you going to operate? Controlled environment. Carcinoma breast. No infective foci. So environment control. Now we have to see the organism. For removing breast, are you going to open GI tract? Are you going to open respiratory tract? Are you going to open urinary tract? Are you going to open respiratory tract? For dividing lymph drainage, are you opening respiratory tract? Are you opening GI tract? Are you opening urinary tract? Is it respiratory tract opening? Tell me. नहीं दिल की नहीं सुननी है ना. Are you opening respiratory tract? Are you opening GI tract? Urinary tract open हो रहा है? ये दिल मांगे मोर मेरे समझ आ रहा है. और पूछूं? What type of wound are you going to have? सोचिए बोलना. In breast abscess drainage. जल्दबाजी हो रही है. तो सोचो तो फिर पहले बोलो मत जब तक सोच रहे हो. 1, 2, 3, 4. Answer is mention नहीं किया. वैसे नॉर्मल ड्रेनेज कैसे करते हैं? इंसिजन एंड ड्रेनेज है. आपने जैसे ही काटा क्या पास बाहर नहीं आएगी? आएगी कि नहीं आएगी? Appa, all of us should be on same page. The moment you give an incision on the skin, won't the pus be out? There will not be gross spillage of already infected material. और पूछता. What type of wound are you going to have in a hip replacement surgery? बताओ मुझे. नहीं बताओ मुझे. You are not going to open urinary tract. You are not going to open respiratory tract. ठीक बात है. And remember, whenever we put an implant in any surgery, just remember this point. Whenever we put implant in any surgery, we write D as a suffix. D as a suffix. So it will be a 1D wound. Whenever we put an implant in any wound, we are supposed to write D as a suffix. So in hip replacement, we are putting implant. So it will be a 1D wound. Understood? और पूछूं? दिख रहा है मुझे. Now listen to this. What type of wound are you going to have in a inguinal hernia repair? Two. Okay. Now what we do? Now let me tell you that what we do in inguinal hernia. We give incision on the skin, subcutaneous tissue, fascia scarpa, fascia camphor, external oblique aponeurosis, right? Then we take out the cord, and then from the cord we dissect the sac, the hernial sac, right? And then we open hernial sac. That is, hernial sac is nothing but the peritoneum. We open peritoneum and we push the content back in the abdomen. Close the hernial sac. This is called herniatomy. Otomy, herniatomy. So you push the content back, close the hernial sac, and then you close the abdomen. Close it. So what type of wound? Why would it be clean contaminated? We are not opening GI tract. We are not opening respiratory tract. What is leptospora? Thorax? Intestinal hernia to छोटा ही. That is called enterocele. That is not intestinal hernia. No. When you open intestine, you are not opening intestine, you are pushing the content back. Then it is full. Another question. What type of wound are you going to have in a supraclavicular lymph node excision? तो करो रेस्पिरेटरी लिम्फ नोड क्या होता है सुप्राक्लेविकुलर लिम्फ नोड की बात हो रही है इनके लिए सुनने दिमाग लगाना है ठीक है ये मोड ठीक है ओके लास्ट what type of wound you will have once a patient comes to you with a lacerated wound after road traffic accident. ये कब तक एक रहेगी पिछले के अब तक चलती रहेगी क्या but if you don't do anything for this wound and patient comes to you after 4 hours जब तक 4 hours नहीं हुए तब तक 3 है उसके बाद 4 है simple. One last question. Okay, what type of wound are you going to have when you're doing a tracheostomy in a trauma patient? Emergency tracheostomy in trauma. Emergency tracheostomy in trauma. Emergency tracheostomy in trauma. Emergency tracheostomy in trauma. It is if you are doing a elective tracheostomy. Elective tracheostomy, emergency tracheostomy. Why emergency tracheostomy was free? Why it is not controlled? कहाँ करेंगे हम tracheostomy? Bedside. So that means the environment is. समझ आ गई बात? Everyone? Yes, sir. Good. And the surgical wound सबको समझ आ गया? ऑल ऑफ अस आर ऑन सेम पेज, राइट? अगर कहीं पे भी कोई दिल में नहीं रखना है, विद मी यू शुड आस्क एनीथिंग, यू कैन आस्क एनीथिंग. एनी क्वेश्चन? पक्का? हाँ यार, एक तो तूने मास्क लगा रखा है, लगाया ना, बट थोड़ा तेज बोल. वो एक मिनट, एक मिनट. डी का फुल फॉर्म नहीं है, कोई फुल फॉर्म नहीं है, डी लगाते हैं बस, राइट? ठीक है. इलेक्टिव ट्रिकोस्मी क्लास 2. रेस्पिरेटरी ट्रैक ओपन नहीं हो रहा. Elective tracheostomy, normally we don't do it for an infected scenarios, right? Then comes now if a surgical wound, समझ आ गया? पक्का? तू बस देख रहा, मुझे मेरे को लग रहा है नहीं समझ आया. So now surgical wound getting infected, this is a classification of surgical wound, and surgical wound getting infected is called surgical site infection. Surgical wound getting infected is called a surgical site infection, right? And surgical site infection is the most common cause of post-operative morbidity. Surgical site infection is the most common cause, of post-operative morbidity. And please note this very important point. Any surgical wound, if gets infected within 30 days, or any surgical wound which has an implant inside it getting infected within 1 year, will come in the definition of a surgical site infection. Agar koi surgical wound, if any surgical wound has an implant inside, like hip replacement surgery you have done, and after 3 months this hip replacement wound get infected, it will still be called a surgical site infection. Once the implant is there in any wound, the definition of surgical site infection is still 1 year. And if the implant is not there, the definition of surgical site infection is if the wound is getting infected within 30 days. Right? Now, the most common organism involved in surgical site infection, a very commonly asked question, is Staph aureus. The most common organism involved in surgical site infection is Staph aureus. Now, we know, you can appreciate that we don't want our surgical wounds to get infected. We don't want our surgical wound to get infected, because if they get infected, there will be a post-operative morbidity. So we don't want that morbidity to happen to any of our patients. So what all should we be doing to prevent surgical site infection? What are the things we should do to prevent a surgical site infection? These are the type of questions they ask you in exam these days. So what are the things we should do to prevent a surgical site infection? One most important thing to prevent surgical site infection is optimization of the patient. Optimization of the patient. What do you mean by optimization of the patient? Dekho, please understand this. Emergency surgery, you can't do anything about it. If there is some emergency, you have to do. You can't can't select the patient in emergency. You have to do an emergency surgery at any cost, right? But when you are doing an elective surgery, you can take care of the factors which can prevent surgical site infection. So in that, the most important factor is optimization of the patient. What does optimization means? Say, for example, if the patient is diabetic, we know a diabetic patient, if has a surgery, the chances of diabetic patient to develop a surgical site infection are more than a normal patient. So we always should try to control diabetes as far as possible, as much as possible. The control on diabetes is there, lesser are the chances of this patient to get a surgical site infection. So if the patient has an uncontrolled diabetes and he is planned for an elective surgery, prepare this patient by controlling the diabetes first, optimize his diabetic control, and then subject this patient to a surgery. So one of the factors which is to be optimized is diabetes. Then second important thing which can lead to a surgical site infection which requires optimization, a patient who are on steroids. Those patients who are on steroids, they also have a risk of developing a surgical site infection. So we should try to control the dosing of steroids. If possible, the patient should be off steroids before we subject them to a surgical procedure. But then there are times the procedure, the condition is such that you can't stop steroids. The patient has to take steroids. So in such conditions, what we do, we try to make sure the patient takes as minimum dose of steroid as possible. Patient should take as minimum dose of steroid as possible. So second important factor which needs optimization is steroids. Third thing which needs optimization is malnutrition. If the patient is malnourished, if you subject this patient to a surgery, there are very high chances of a surgical site infection. So you should build the nutrition of the patient before you subject the patient to a surgical procedure. So you should improve the nutrition of the patient before you subject this patient to a surgical procedure. So these are some of the things which needs optimization. Then the second thing which is required to prevent a surgical site infection is जितना टाइम लग रहा है लगे. Yes, yes, you can't do anything, right? So you should optimize the patient and subject them to a surgery. Then second thing which is important here is minimum movement of the operative staff. Minimum movement of the operating room staff in operating room. It is not a company garden that you are moving. You all have seen that in OT there is a restricted area. You can't enter. So that is there to prevent a surgical site infection. Then third, you all must have seen that before a patient is subjected to a surgical procedure, hairs are removed from the operating field. How to remove hairs, when to remove hairs, what is the guideline? How to remove hairs? The latest guideline says we should never remove hairs. We should not remove hairs. Because whatever method of hair removal you are going to use, there are going to be microabrasions, and those microabrasions will be the site of colonization of bacteria. But then you can appreciate that if you are operating on an area which is having a dense growth of hair, or if you are going to operate on an Anil Kapoor. So if you are going to operate on an Anil Kapoor type of a person, to get into the exposure, to facilitate your exposure, you have to remove hairs. Hair removal guideline says don't remove hair. If the area which you are going to operate doesn't have a hair growth, much hair growth, no need to remove hairs. But if the area is such where there is a dense hair growth, you should remove it. But how will you remove it? What is the best method of removal? checked in exam. Hair clippers. You should use hair clippers, no razors, right? And when should we use these hair clippers? Where to use these hair clippers? पेंसिल की गई नहीं बैटरी तो उसकी है अरे रुक जा यार रुक जा ठंड hair clippers where to when to do this hair clipping on table on operating table not dining table on operating room table, right? That is the best time. Then you all must have seen that the surgeon scrub before the surgery. How the surgeon should scrub, what should he use for scrubbing, and for how long he should scrub. The surgeon water should run from the tip of the fingers to the elbow, never from elbow to the tip. You all have seen the surgeon stands like this. So for how long, what should he use for this scrubbing? Light boy. He should use chlorhexidine solution in alcohol base. For this scrubbing, surgeon should use chlorhexidine solution in alcohol base. And for how long the surgeon should scrub? 3 minutes, 5 minutes, 7 minutes, 10 minutes, half an hour, 1 hour. Minimum of 5 minutes. Right? And then you all must have seen the surgeon paints the area also. You all must have seen the surgeon paints the area also. How the surgeon should paint the area, what should he use for this painting, and how many application of that paint should be applied. Imagine you are going to operate on abdomen. What area are you going to paint? You are doing a laparotomy. What is full abdomen? Earlier, we were doing it like this. Nipple to mid-thigh, like this, from above down. Nipple to mid-thigh, and then the external genitalia. The area to be painted was, earlier, nipple to mid-thigh, including external genitalia, and we used to come from above to down, like this, vertically. Now it is not like this. What we do now is this. Now what we do is this. The centrifugal painting. And in that, the last part to be painted is external genital. The area painted is still nipple to mid-thigh, but the painting should be done centrifugally. Centrifugal, like this. Centrifugal like this. And now, what are we going to use for this centrifugal painting? We should use again, no betadine here, chlorhexidine solution in alcohol base again. And how many applications? How many applications? Only one application. आपका दिल कहेगा कि 3 या 4 कर दो, बट करनी एक ही है, right? So minimum 1, okay? And then you should not wipe it. Once you have painted the area, you should not wipe it. You should let it get dry, right? Then comes the flow of air the flow of air, you should let it get dry, you should not wipe it, and only one application is sufficient. Then, okay, now then,
How do you decide the previous or liquid?
How
do you decide the distance of how much you take?
It is always nipple to mid-thigh.
No, that is
so we don't decide. It is always nipple to mid-thigh, including external genitalia. Obviously, if you are doing a surgery on arm, why would you paint abdomen? Patient will run away. Patient will run away if you do that. The basic idea is you have to cover the joint above and joint below. Right? But then they will not check you on that, they will check you on abdomen. Right? Now, then the flow of air. The flow of air in your operating room should be a laminar flow. What is laminar flow? Either say there is inlet channel and outlet channel is in front. So there should be a laminar flow of air. There should be a laminar flow. And very important point, there are few operating rooms which need to be ultra clean. So what are the ultra clean operating rooms? Which operating rooms needs to be ultra clean? The ultra clean operating rooms should be operating rooms where we use implants. Neurosurgery operating rooms, cardiac operating rooms, and ortho operating rooms. Neurosurgery, cardiac, and orthopedic operating rooms are the operating rooms we should be having a ultra clean air. Okay. Then comes a very important discussion. That is about a prophylactic antibiotic. When to give a prophylactic antibiotic and which surgery requires a prophylactic antibiotic is important. If you are going to get a class 1 wound, if your surgery is such that you are going to get a class 1 wound, you don't need any prophylactic antibiotic. No prophylactic antibiotic required, right? But if you are doing a surgery where you are putting an implant, if it is 1D, only prophylactic antibiotic required. If you are doing a surgery where you are putting an implant, it is a 1D wound you are expecting, only prophylactic antibiotic required. If it's a class 2 wound, again, only prophylactic antibiotic required. Only prophylactic antibiotic required. But if it is a class 3 and class 4 wound, not only prophylactic, but also therapeutic antibiotic required. Now comes, what is the best time of giving this prophylactic antibiotic? Before surgery. Before surgery can be any day before surgery. Yeah? 30 minutes before surgery. The best time of giving this is at the time of induction of anesthesia. Not incision, minded. It is at the time of induction of anesthesia. Right? If not in your choice, then it is 1 hour. If at the time of induction of anesthesia is not there, then 30 minutes. At the time of induction of anesthesia is a better answer. If not there in the choice, then 30 minutes before surgery. 30 minutes before surgery. If that is also not there, then 1 hour before surgery. तो इसीलिए तो क्या क्या देना हो? नहीं, मेरे को समझ नहीं आता, करो। पोर्ट किसका पोर्ट? कीमो पोर्ट। अच्छा, जरूरत नहीं, क्लास 1 वुंड है तो जरूरत नहीं। ठीक है, अच्छा, ये आज का क्वेश्चन। Let's see who will answer. He asked, sir, for putting a chemo port, do we need to give a prophylactic antibiotic? पहले तो हमें पता होना चाहिए कीमो पोर्ट है क्या, तब तो हम बात करें आगे। A patient who is in having a malignancy, a patient who has a malignancy, for giving a chemotherapy, we put a chemo port. For giving a chemotherapy, you can appreciate that for giving a chemotherapy, you have to put a cannula in the IV line, right? So chemotherapies are usually given at a multiple times. Multiple times patient needs a chemotherapy. So that means every time you have to put a cannula. Okay. So instead of that, what we do, we insert a port inside the body, in the vessel, and that port is put in the subcutaneous plane under the skin. And every time when the chemotherapy is to be given, that chemotherapy is inserted in that chemo port. Rather than every time puncturing the vein, there is in the subcutaneous plane, there is a chamber which is going into the great vessel, and you insert a cannula in that chamber. That is called chemo port. Now his question is that, sir, for chemo port insertion and for removal, do we need to give a prophylactic antibiotic? What type of wound are you going to have in a chemo port insertion? Class? And in class 1 wound, is there a implant inside? Yes or no?
Yes, sir.
This chemo port is what? Implant or not? There is an implant. It's a 1D. So prophylactic you have to give. ठीक है ना? Since there is you have put it something inside which will remove later, that's a different thing. But you have put something, so you have an implant left inside. So 1D. So prophylactic antibiotic. ज़्यादा? ठीक है? अब आई बात. So this is the time when you give a prophylactic antibiotic. Now we do these many things to avoid a surgical site infection. But what if the surgical wound get infected? What to do if the surgical wounds get infected? We are trying hard, not trying hard so that the surgical wound doesn't get infected. But what if it gets infected? We have to manage it, right? So once a surgical wound get infected, it is like any other wound infection. Now it's a wound infection. We have to manage it. Now, how to manage a wound infection? Now, before we understand a management of a wound infection, we have to first know that there is a classification and there is a score. There is a classification and there is a score for a wound infection. Please note that this is a classification or a score for wound infection. What is that classification called? Southampton classification and a sepsis score. There is a Southampton classification and there is a sepsis score. These are the two things which we have for classifying and scoring a surgical site infection. For classifying and scoring a surgical site infection. Okay, we don't need to go into the detail of this. We just need to know these are the classifications and scores for surgical site infection. Now, what to do when the wound gets infected? In wound infection, we have to do two things. Local wound care, and a systemic wound care. How are we going to do a local wound care? How are we going to do a systemic wound care? We need to know. And this is a very important thing. As an intern, you will be doing all this. So this comes as an important thing for you. Now imagine I have done a laparotomy. Right? And this laparotomy wound got infected and started draining fluid. The fluid started coming from this wound. Right? When a fluid starts coming from the wound, a wound is most likely infected. What to do? What will be your immediate next step? Very good. Immediately remove sutures. Immediately remove sutures. The moment you remove sutures, the collected thing inside will get a vent to come out easily. So the secretions, the collections should not get pent up. So we immediately open a wound. This is the first step. And after that, we will send this fluid which is coming for a culture and sensitivity. We will send this fluid which has come out for microbial culture and sensitivity. Till the time the report comes, we will do the dressing of this wound, the local wound care, and in systemic wound care, we give a broad spectrum. We will give a broad spectrum single agent antibiotic. We will give a broad spectrum single agent antibiotic. Okay, right? So you will start taking the care of the wound locally by doing a dressing, and systemic care is going to be by a systemic antibiotic, which is broad spectrum single agent, not multiple agent mind. Right? Till the time the culture report is available. Once the report is available, once this report from culture is available, you will start specific antibiotic. Whatever antibiotic on culture bound to be sensitive. This is how you do a management of a wound infection. Very, very important algorithmic approach. Any doubt? How are you managing now? By secondary intention. Till the time, if it gets healthy, दो पूछो। तो तुम रोल करके देखते हो, वो इज नॉट अ राइट वे. पस निकालना है. बेटर इज टू द पस और वट एवर फ्लूइड इज कमिंग should have a easy access for coming out. You should remove the suture so that the fluid should come out easily. It is not that you press it and then you are expecting it. उसमें पूरा नहीं निकलेगा ना, उसमें पूरा नहीं निकलेगा. कर गलत नहीं है, कर सकते हो, but it is not right guideline. ऑलरेडी इन्फेक्टेड है. सेकेंडरी इंटेंशन से हील करेंगे एंड देन लेटर ऑन इफ रिक्वायर्ड विल डू अ डिलेड प्राइमरी क्लोजर. अंडरस्टूड एवरीवन? ओके. ठीक है. Now, once the wound get infected, the patient, you can appreciate, can go into septic shock also. Yes or no? So, how the patient goes into septic shock, we should see. The first thing, whenever there is, you can appreciate, will there be a microorganism invasion once wound get infected in the body? There will be microorganism invasion. So whenever there is a microorganism invasion in the body, the first thing that the individual is going to develop is surs. Because of this wound infection or because of any microorganism invasion, the first thing the individual is going to develop will be surs. What is surs? Systemic inflammatory response syndrome. Systemic inflammatory response syndrome. What are the features of SIRS? We need to know. Temperature less than 35 degrees Celsius or 38 degrees Celsius. Heart rate more than 90. Respiratory rate more than 20, and TLC count of these patients will be either less than 4,000 or more than 12,000. So by opening your wound, by letting the pus come out and giving a systemic antibiotic, we are trying the patient to not progress from SIRS to further stage, right? But if we delay of our patient's management, the patient of SIRS can progress to sepsis. What is sepsis? Sepsis is SIRS with documented blood infection. SIRS with documented blood infection means blood culture positive. You can appreciate if you delay in starting your antibiotic, the bacteria which was local earlier can go into the bloodstream and can lead to sepsis. If the patient is not taken care at this stage, sepsis, or the virulence of organism is so high that even when you are taking a care, patient progresses to a severe sepsis. What is severe sepsis? Sepsis with one or more. It is not two, it is one or more. Answer in your MCQ source is not right. One or more organ dysfunction. One or more organ dysfunction. And if the patient is not taken care even at this stage, patient will develop septic shock. Shock laga, shock laga, shock laga. What is septic shock? Septic shock is sepsis-induced hypotension. Sepsis-induced hypotension that persists despite sepsis-induced hypotension that persists despite adequate fluid resuscitation and requires vasopressor support. And this is a very difficult stage once the patient is in, because after this, the patient develops a multi-organ failure and the patient ultimately succumbs. Right? So we should be very prompt in managing any infective foci present in the body. Okay. Now, to assess the severity of septic shock, to assess the severity of septic shock, we have a score called SOFA score. To assess, to assess the severity of septic shock, we have a score called SOFA score. What is SOFA score? Sequential organ failure assessment score. Sequential organ failure assessment score. In this SOFA score, we need to know what are the parameters we have. We don't need to go into the detail of this, but we should know what are the parameters we have there in this SOFA score. The parameters there in SOFA score are PaO2 to FiO2 ratio, PaO2 to FiO2 ratio. We have GCS. What is GCS? We have mean arterial pressure. So इसका मतलब क्या हुआ? GCS is not only there for trauma. GCS is a neurological assessment of any patient. Mean arterial pressure, serum bilirubin, platelet count, and serum creatinine also. These are the 6 parameters there in a score called SOFA score, which tells us the severity of septic shock. Then we also have another score called quick SOFA, Q SOFA. We also have a quick assessment of a patient also. We are now in an era of shortcuts. Jaldi chahiye cheez hame. We can't wait. So we have a shortcut also, and that is called quick SOFA. In that quick SOFA, we have systolic blood pressure. If it is less than or equal to 100 mm of mercury, the score given will be 1. Respiratory rate, if it is more than or equal to 22, score given will be 1. GCS, less than or equal to 14, score given will be 1. So any patient if has a quick SOFA of more than or equal to 2 at the time of admission. कोई आपके पास ऐसी condition में आया, a patient has come to you in such a condition that Q SOFA of the patient is more than or equal to 2. It is very likely that this patient has a longer stay in hospital, and it is also possible that he has a high risk of mortality also. So this is called Q SOFA. Okay, so these are the scores which we need to know in our discussion on general surgery. 10. ये 3 पैरामीटर्स कहीं और भी दिखे हुए, किसी और स्कोर पे करें, और सोचो और कहाँ थे? अभी थोड़ी देर पहले डिस्कस किया है। नहीं किया तो कहाँ किया बताओ? रिवाइज ट्रॉमा स्कोर, रिवाइज ट्रॉमा स्कोर में थे नहीं 3 पैरामीटर ये। Okay, so this is about our discussion on the scores in general surgery. Then comes in general surgery, let us talk about sutures. Let us talk about sutures now. Now, first of all, I'll again try to make you understand the concept here. But then, before we understand the concept, we need to remember this classification of sutures, which is very important. The sutures are classified into non-absorbable and absorbable sutures. Sutures are divided into non-absorbable and absorbable sutures. As the name suggests, absorbable sutures are going to get absorbed. Absorbable sutures are going to get absorbed. And how do they get absorbed? A question asked. They get absorbed by enzymatic hydrolysis and is the speed fine? And phagocytosis. Enzymatic hydrolysis and phagocytosis are the means of these sutures to get absorbed. Now, in absorbable sutures, we have further classification: synthetic, and natural. In absorbable, we have synthetic and natural. In natural, we have catgut. Now, what is this catgut? Catgut is a suture material derived from, very important, submucosa of sheep or cattle gut. Submucosa of sheep or a cattle cut. Now, important point to note in this catgut suture material is, now since it is derived from a natural source, it has a property of spontaneous disintegration. It can get disintegrated spontaneously also. So to prevent its spontaneous disintegration or degradation, we always keep this suture material in a pack with a solution inside. So you may be asked that as an intern, you are told to take out a suture. The moment you opened a suture, a liquid came out from that suture. What suture is kept in a liquid? They can ask you this, or they can ask you what liquid is there. So this is a preservative solution for preventing the degradation of catgut, and that preservative solution is isopropyl alcohol. Isopropyl alcohol, and it's an absorbable suture material, and this absorbable suture material loses its strength in 7 to 10 days. It loses its strength in 7 to 10 days, right? And then we also have chromic catgut. Then we also have chromic catgut. Chromic catgut is a catgut suture with chromium salt impregnated on it. Chromic catgut is a catgut suture only with a chromium salt applied over it, and this loses its strength in 10 to 14 days. So it is actually chromium salt delays its degradation, right? So this is about the absorbable natural. In synthetic natural, we have vicryl, which is also called polygalactine. Vicryl, which is also called polygalactine, and this suture material gets absorbed completely by 3rd month. This suture material gets absorbed completely by 3rd month. Then we also have monocryl, which is also called polyglycapron, which is also called polyglycapron, and this also gets completely absorbed in 3 months. We also have polydiapsonol, also called PDS. Polydiapsonol, which is also called delayed absorbing suture, which is also called delayed absorbing suture, and it gets absorbed in 180 days. Then in non-absorbable sutures, we have अभी तो बोला चलो मजाक किया था मेरे साथ, मेरी भावनाओं के साथ। अब चलेंगे। Can we go ahead? Now, in non-absorbable sutures, we have again synthetic and natural. In non-absorbable also, we have synthetic and natural. In natural, we have silk, we have linen. In natural, we have silk, we have linen. In synthetic, we have nylon, which is also called polyamide. We have proline, which is also called polypropylene. We have polyester also. Polyester. Okay. Now there is another classification also. That classification is braided, which is also called polyfilament. There is another classification called braided, or polyfilament, and we have non-braided or monofilament. Braided or polyfilament, non-braided or monofilament. Okay, now please listen to this carefully. What is braided and what is non-braided? See, if I take this suture, imagine this is a suture. If I take this single strand and start using it for suturing, it is a monofilament suture or non-braided. If I take multiple such strands like this and move them together and form one suture out of it, it is braided or polyfilament. If you use only one strand of a suture, it is monofilament or non-braided. If I use multiple such strands and move them together and form a single suture out of it, it is polyfilament. Now, out of all absorbable sutures, Vicryl is the only braided polyfilament absorbable suture. Vicryl is the only braided polyfilament suture. Rest all are non-braided monofilament, except for the Vicryl. Rest all are monofilament, non-braided. Vicryl is the only braided suture material we have. In a non-absorbable sutures, except for nylon and proline, except for nylon and proline, rest all are polyfilament braided. Except for nylon and proline, rest all are polyfilament braided. So that means these two are monofilament or non-braided, one and the same thing. Okay, अब देखो important, हम एक concept बनाएंगे so that we can decide what suture are we going to use when. So I'll try to make you understand the concept here. For understanding the concept, you have to understand the property of a suture material. Okay, and please try to understand these properties. And once we understand these properties, it will become very easy for us to decide a particular suture in a given situation. Dekho, first of all, you can easily relate with it. Suture material is a foreign body. Yes or no?
Yes.
So if there is a foreign body, there will be inflammation against it, right? If there is inflammation, there will be fibrosis also. And if there is a foreign body, there will be a foreign body reaction also. There will be allergic reaction also. Now you tell me, out of natural or synthetic suture material, which of them will have more chances of a foreign body or allergic reaction? Which of them will have more chances of an allergic or a foreign body reaction? Obviously, natural, because they are derived from different species. So that means allergic reaction and foreign body reaction will be more with the natural suture material. So the latest guideline says that we should avoid using a natural suture material. We should use the synthetic suture material, right? On a suture material, you will find written 1O, 2O, 3O, 4O, 5O like this. On a suture material, you will find written 1O, 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 2O, 3O, 4O like this. Now, as this number is increasing, the thickness of a strand of suture material, is decreasing. Thickness of a strand of a suture material is decreasing. देखो 1O, 2O, 3O लिखा हुआ है. तो कुछ और लिखा हुआ है. 2O, 3O, 5O, 6O लिखा हुआ ना. These colors are important. The colors of the sutures. Please be careful. Right? So, as this number is increasing, the thickness of the strand of the suture is decreasing. So, as the thickness of the strand is decreasing, you can appreciate that the tensile strength, the breakability of the suture will be जितना पतला होगा उसे तोड़ना आसान होगा, मुश्किल होगा? So tensile strength of the suture will be decreasing, no? Right? And then the inflammation due to suture also will be less. Fibrosis from the suture will also be less. So when inflammation and fibrosis due to suture is less, fibrosis of the suture is less, so the scar due to suture itself will be lesser. Scar due to suture itself will be lesser. So that means in any area which is cosmetically important, any area which is cosmetically important, like face, we should use a higher number suture so that the scarring due to suture will be lesser. So all those places which are cosmetically important, we should use a suture with a higher number. Okay. Then another important point, you all must have experienced it in our day-to-day life. If see, this is a monofilament thing, right? This is a monofilament. Agree? I keep it usually this cord like this. When I am not using it, I use it like this, right? But when I open it, you can see that it is coiling. So that means this is a property of all monofilament suture. When I try to stretch them, when I open from a pack, hold the middle end and the tail end and stretch it, they try to go back to their original configuration. So this is called package memory. And this package memory is there only in monofilament suture. This package memory is not there in a braided suture. You take a rope, घर पे rope होती है, उसको कैसे भी fold करके रखो, and then you take out and leave it. It will fall at a place where you have left it. It will never go back to its original configuration. So all braided sutures, they don't have a package memory. All braided sutures, they don't have a package memory. So package memory is a good thing or a bad thing? Bad thing? Why? It's a bad thing. Absolutely right. No. When you are taking a suture, you are applying a knot. Every time I am applying a knot, I have to straighten it and then I can apply. Right? And you, all those who are using a charger, all of you are using a charger, after some time you have seen the charger start getting big. Right? This iPhone charger mainly gets just wired at this point. Why is it wired? Because of this package memory, the area where it is getting coiled is getting weakened. So because of that package memory, the monofilament sutures, the strength of the monofilament suture also decreases. So package memory is a bad thing. Okay, but this package memory is only there in the mono. Okay, now imagine think about it, all these points are going to help us in deciding a particular suture. When you are asked a question in exam, there will not be one particular question which they ask. They can ask any question. And then you have to apply these what we are learning here. Okay. Now imagine you are doing a delayed primary closure. You are doing a delayed primary closure and you are doubtful. Like I said that we will put a drain. You were saying that we can put a drain in a delayed primary closure. So you are doubtful that there are chances of infection still. And you are approximating the wound. So should we use a braided suture there or a non-braided? We should use a braided or non-braided? You have a doubt of an infection in a particular wound, you are not very sure, and you are taking a chance by closing it. Should we use a braided or non-braided? Obviously non-braided, because if you use braided, the bacteria will get trapped in the braids of the suture and then it will become difficult to... Okay, very good. Good. Now, tell me, there is a suture material through 3O. One suture material, 3O. One 3O is a braided, another 3O is a non-braided, which will have a more inflammatory reaction. Obviously, more inflammatory reaction, more fibrosis, more scarring. More scarring. Agreed? So if there is a 3O vicryl and 3O monocryl, which will have a more inflammatory reaction? Agreed? All of you? All of you? All of you? Okay. So, and then, if imagine this happens commonly in our day-to-day practice also. If I apply a knot in this, I have applied a knot, right? Now I want to open it. I have no difficulty in opening it. In a monofilament suture, there will not be any problem in opening a knot because there is no roughness to it. But if there is a polyfilament suture, rope, people use rope for suicide. They don't use a monofilament thing for suicide. Because the moment they use a monofilament thing in suicide, the train slip will die. They use rope because the knot get locked in the braids. If there is a suture which is braided, the knot security in that suture is more than a knot security in a non-braided suture. Right? So these properties we have to keep it in mind while deciding a suture. Okay, now how are we going to decide a suture? एक simple सा rule है. Listen to this carefully. Okay, this is a I don't believe in giving facts. I try to make the student understand things, and then it becomes very easy for you also. देखो कोई भी wound एक rule है. All the wounds are going to be closed in layers. Whatever layers you come across while creating a wound, you have to close those layers also. Right? So all the wounds in the body, wherever they are, they have to be closed in layers, first of all. Okay. And this is a rule. All those layers which are you are going to approximate, if they are providing a strength to the body, if the layers are such that they are going to provide strength to the body, we will always be using a non-absorbable suture, preferably proline or delayed absorbing suture, that is PDS. All those layers which are there to provide strength to the body, we will be using a non-absorbable suture, preferably proline, or we can also use a delayed absorbing suture, that is PDS. Right? All those layers which are being approximated, having no role in providing strength. All those layers which are being approximated, having no role in providing strength, we will approximate them by a absorbable suture, preferably vicryl. All those layers which are there to provide strength, we will use proline or delayed absorbing suture, that is PDS. All those layers which are being approximated, having no role in a strength, we will use absorbable suture, that is vicryl. Now with this understanding, let's close a particular wound. When we close a particular wound, you will have a better understanding. Right? Imagine I am doing an appendectomy. We'll be talking about that in GIP. In appendectomy, we will give an incision. Okay. Where we give incision, what are the various types of incision, we'll talk about there. Right? We give incision at McBurney's point. What is McBurney's point? We'll discuss there. This is a McBurney's point. So we give incision like this. Now, what all layers are going to come? Let's see. You divide skin, then you divide subcutaneous tissue, then you divide fascia scarpa, fascia camphor, then you divide external oblique aponeurosis. Once you divide external oblique aponeurosis, you separate the fibers of external oblique. Then you have internal oblique and transversus abdominis muscle. You separate internal oblique and transversus abdominis muscle, and then once you separate them, there is a peritoneum. You divide peritoneum, and then you do appendectomy. Now you have done appendectomy, imagine, and now you are closing it. So we have to close everything in layer. So we start from below and come up. So first layer is peritoneum. Peritoneum. Is peritoneum there to provide strength? Peritoneum is a cover. It is not there to provide strength. So what suture? Vital. External oblique aponeurosis is there to provide strength. External oblique aponeurosis is there to provide strength. It is there to provide strength. So what suture? Proline or PDS, preferably proline. Then fascia scarpa and fascia camphor. These are the fatty layers. Are they there to provide strength? No. So what suture? Vital. Then comes a subcutaneous layer. Subcutaneous layer has fat. Is there to provide strength? No. So that means we have to use absorbable suture. But here specifically we have to know. Since subcutaneous layer is just beneath skin, we don't want to use that suture which cause more inflammation. We have to use absorbable, but we will use that absorbable suture which has a lesser inflammation or lesser fibrosis subsequently. So out of vicryl and monocryl, which will have a lesser fibrosis and inflammation? So specifically for subcutaneous layer, we will use monocryl. Specifically for subcutaneous layer, we are going to use monocryl. Every time. Right? Then for skin. Skin is there to provide strength? Yes. So we will use non-absorbable suture. We can use absorbable also, but we prefer using non-absorbable. In that, we can use proline, but we commonly use nylon. अगर ये कंसेप्ट समझ आ गया, आप कहीं भी आंसर कर सकते हो. Let me ask you, what suture are you going to use for tendon repair? Proline, agreed? What suture material? No, I can't write. So for using for places where you need to provide strength. So I'm writing places where you need to provide strength. We will use non-absorbable suture, preferably proline. We can use PDS also, but preferred is proline. For all other places, vicryl, except subcutaneous layer, where we will use monocryl. Now for tendon repair, you already answered proline. For bone repair, if you have to use a suture, bone is there to provide strength. We don't use a suture for bone though, but if you have to use, it is proline. But what we use? We use nails, we use screws, we use plates. What are they made up of? Titanium. Stainless steel or titanium. And what is this stainless steel and titanium? Nothing but non-absorbable thing. So concept is same, right? And you should know that stainless steel is the most inert substance which we are using for in any place. It is the most inert. No reaction. Body has a least reaction against it. MRI नहीं कर सकते और बॉडी के इन्फ्लेमेटरी रिएक्शन कम हो रहा है. ठीक है? Now just remember, okay, let me ask you, for a fascia lata, what suture? Fascia lata, they provide proline. Rolling. Okay. Right? So now you have understood the concept. So what we have understood, let me tell you again that all the wounds should be closed in layers. This is what I told you, except one wound. Remember, all the wounds in the body are closed in layers, except one wound. What that one wound is? Very good. Midline laparotomy wound. All the wounds are going to be closed in layers, except midline laparotomy wound, which is closed by continuous mass closure technique, which is closed by a continuous mass closure technique. What is this continuous mass closure technique? Let's understand. This, imagine, is a laparotomy wound. First of all, what we do in this, what are the layers we are going to come across first of all? We have skin, subcutaneous tissue, fascia scarpa, fascia camphor, linea alba, and then peritoneum. These are the layers which we are going to come across. Skin, subcutaneous tissue, fascia scarpa, camphor, linea alba, and peritoneum. Instead of closing it in layers, we do a continuous mass closure. What is continuous mass closure? Let's understand. What we do here, we insert a needle from the subcutaneous plane. Skin, beneath skin, there is a subcutaneous. We insert a needle from subcutaneous out to in. And instead of coming out just at the subcutaneous layer, we go deep down to the peritoneum. Just go down till the peritoneum. So you are inside now. Then you come to the opposite side. From peritoneum again, you will insert a needle and come out on the subcutaneous layer in one bite. Now you will apply a knot here. Then the same suture will run throughout the length of the wound. This is called continuous mass closure technique. Now, first of all, tell me, what suture are you going to use for this continuous mass closure? Simple, we should use Prolene. And remember, whenever, as a rule, we don't want a tension in any wound, because you have seen that whenever the wound is closed in tension, there is a problem in wound healing. Local tension in the wound you have written. So to avoid tension in a wound in a continuous mass closure technique, we follow a rule called Jenkins rule. We follow a rule called Jenkins rule, and that rule is suture to wound length ratio. Four times the length of the wound we have, so that in a continuous mass closure or continuous closure, there is no tension. This is called Jenkins rule. This is called Jenkins rule. Whatever is the length of the wound, we have to use 4 times the length of the suture. देखो मानो ये suture है, ठीक है, ये लेंथ है मेरा suture, बट wound जो है इससे बड़ा है, तो क्या होगा जब मैं कंटिन्यूस suturing कर रहा हूँ तो मेरा suture खत्म हो जाएगा, इससे जबरदस्ती करने की कोशिश करूंगा तो टेंशन होगी, तो नहीं करना। आपको अगर ये लेंथ है wound की, तो आपको इसका 4 टाइम्स suture लेना। सुचर का ऑलरेडी लेंथ 100 सेंटीमीटर तक आती है। However obese you are, so we will not use a continuous technique in that. कोई कसम थोड़ी खा रखी है ऐसे में लगा के। और क्या, जहां पे कंटिन्यूस हो सकता है, अगर सूचर वुंड लेंथ इतनी आपके पास सूचर उतना लंबा है ही नहीं, ऐसा होता नहीं है, क्योंकि ऑलरेडी हमारे पास सूचर जो है 100 सेंटीमीटर के होते हैं, 1 मीटर का तो सूचर ही है, इतना बड़ा कौन सा वुंड हो जाएगा बॉडी में। मैक्सिमम जो लंबे से लंबा वुंड होता है वो लेप्रोटॉमी वुंड होता है, और वो आपका 1 मीटर का सूचर है, तो अगर वो 10 सेंटीमीटर, ये 7 सेंटीमीटर है, राइट, अगर 20 सेंटीमीटर भी हो गया 4 टाइम्स, मतलब कितने तक जा सकते हो आप, 25 तक जा सकते हो, 25 सेंटीमीटर, 25 सेंटीमीटर इतना बड़ा होगा अराउंड, इतना बड़ा होता है, ठीक है, राइट। Okay. For visceral approximation, also we have to use suture. In which there is a potential of stone formation. All those viscera where there is a potential of stone formation. All those viscera in which there is a potential of stone formation. We should not use non-absorbable suture. We should always use absorbable suture, preferably vicryl. So that means for CVD repair, for gallbladder repair, for ureter repair, for bladder repair, for kidney repair, we will use vicryl. All those viscera which have a risk of stone formation. All those viscera which have a risk of stone formation. We will use absorbable suture, that is vicryl. Okay? Now comes the intestinal anastomosis. For intestinal anastomosis, what were we doing earlier? We were earlier using a 2-layered closure. For intestinal anastomosis, earlier we were doing a 2-layered closure. What is that 2-layered closure? Imagine this is intestine. There is mucosa, there is submucosa, there is muscularis, and there is serosa. Right? So these are the layers. You don't need to know the 2-layered closure because we don't do that anymore. We do a single layer closure. Earlier we were doing a 2-layered closure. You just need to know earlier we were doing a 2-layered closure. Now we do a single layer closure. What is that single layer closure? That single layer closure is called extra mucosal repair or Matheson's repair. Extra mucosal repair or Matheson's repair. Extra mucosal repair or a Matheson repair. What is this extra mucosal repair? Let's understand. What we do here, imagine this is a needle, right? This is a needle. What we do here, we insert a needle from serosa. Serosa से हम out से in जा रहे हैं. We enter the needle from serosa. Now, instead of coming out through and through, this is mucosa. Instead of I coming out through and through like this, I will not come out like this. I will come out like this, behind mucosa. I will not take mucosa in my bite. I will come out behind mucosa. Okay, it is not through and through bite. It will be behind mucosa. That means what all layers I have taken? I have taken serosa, muscular, and submucosa. And then I will enter from outside also, behind mucosa, and come out on serosa. Again, from opposite side, I will enter behind mucosa, not including the mucosa in this, and come out on serosa. And then I'll apply knot. This is called extramucosal Matheson repair. For this repair, the guideline says you should use PDS, but commonly we are using silk. We do extramucosal repair here. We don't do two-layer closure. We do extramucosal repair. Means we take a bite from the serosa, and instead of coming out through and through, we come out behind mucosa, including some mucosa in this bite. And then we enter. From the opposite side. Then we enter from the opposite side. Again, not taking mucosa in the bite. We enter behind mucosa, taking some mucosa, muscularis, and serosa, and come out. So this is called extra mucosal repair or Matheson's repair. Okay? You can use silk also. You can use PDS also. Because with silk, there are basically silk और PDS में advantage क्या है? Silk में chances of infection ज़्यादा है because braided है. PDS is non-braided. ठीक है? So this is a extra mucosal repair called method. Now अब बताओ मुझे what suture material are you going to use for gastrojejunostomy? PDS, intestinal anastomosis. Agreed? All of you? What suture material are you going to use for hepatico jejunostomy? सोच के बोलो. ये एनास्मोसिस किसमें हो रहा है? Ostomy, making an opening between the two structures and leaving it open. What are the two structures? कौन-कौन सी structure है ये? Hepatic duct. We don't anastomose with liver. We do anastomosis with hepatic duct and jejunum. तो क्या सूचना यूज करें? Because hepatic duct has a risk of stone formation. Understood? We'll use right. Okay. Okay. If you are doing a uretrosigmoidostomy, so now you understood the concept. You don't have to remember. Otherwise, what you were doing earlier, you were just remembering this. Now you can apply your common understanding and answer easily now. Now in your brain, now you can answer easily. Okay, now once we use a suture in any surgery, we have to apply knot also. right? So there are mainly three types of knots we have. There are three types of knots, and these knots we have to know how to identify. You don't have to remember this extra half is on brief knot, not required together. You just have to remember brief, which is also called square knot, granny's knot, and a circus knot. Right? Now, if you look at it carefully, you will find square knot is very easy to identify. Square knot में कभी confusion नहीं होगा. If you look at it, there are multiple squares which is not there in any other knot. So surgeon's knot is very easy to identify. But these two knots are difficult because they look more or less same. What students do? They try to, they see YouTube videos and try to, make a knot and try to understand that what type of knot it is. At your level, you don't have to learn at this stage that how to apply knot. When you come to us for your post-graduation, we teach you. But then at this time, you just have to identify. And very simple way of identification here. You don't have to apply anything here. Just a simple, just look at it here. Look at it here. In a leaf knot or a square knot, this whole loop of a suture is behind these two sutures. This whole loop of a suture is in front of these two sutures. In this whole loop, half of this is front of it, half of the loop, part of the loop is behind it. The same story is opposite side. Once you see this, we are done. समझ आ गया? सबको समझ आ गया? Right? There is no rocket science in it. है ना? And out of these three types of knots, you can easily say which is the safest knot. Obviously, circus knot. नाम ही इसलिए रखा है. आगे पीछे का फायदा भी बताते हैं. इन तीनों नॉट में सबसे वीक नॉट कौन सी है? Grannies tend to slip. So granny's knot is the weakest knot. ठीक है? और granny's knot we usually avoid, but sometimes when we are working in a deep spaces, we may need to apply granny's knot. So when we apply that kind of a knot, this half upper half niche configuration happens. So this is what we need to know about these knots. Any question? Then comes the suturing. There are two types of sutures which we have to know. One is a interrupted suture. Another is a continuous suture. In interrupted suture, we have a simple interrupted suture. We have a mattress interrupted suture. In interrupted sutures, we have simple interrupted. We have a mattress interrupted. Mattress are a further two types. Horizontal and vertical mattress. Just लिख लो फिर मैं बताता हूँ. There is a horizontal mattress and there is a vertical mattress. Vertical mattress suture is applied when there are irregular edges. Horizontal mattress suture is applied when there is a edematous edges. Okay. अब सिंपल क्या होता है और मैट्रेस क्या होता है, लेट्स अंडरस्टैंड. देख लिया. Imagine we are suturing a skin. Just imagine we are suturing this skin. ठीक है. Now imagine this is the skin of the individual which you are suturing. This individual is a thick skin individual. ये जो green part है, imagine is the thickness of the skin. ठीक है. Green part is the thickness of the skin you are suturing. Okay. I'm giving you example on skin, but this is applicable everywhere. Okay. In a simple interrupted suture, whatever two edges you are approximating, whatever is the thickness of the tissue which you are approximating, imagine this X is the thickness of this tissue, skin. So what I'll do, I will insert my needle at right angle. Right angle. The needle is to be inserted on right angle. At any time I insert a needle on a tissue, I will insert in a right angle. This was the question asked. Okay. तो मैं इस टिश्यू को पकड़ूंगा फोर्सेप्स से और from free edge of this tissue, I'll take X distance, the same distance which is the thickness of the tissue I am approximating. So I'll insert a needle X. Imagine 1 centimeter is the X here in this scenario. So I'll take 1 centimeter away from the free edge of this tissue, enter a needle. So I'll enter from here, out, in. So I have entered now. Okay. Then I'll come out again X distance from the skin again. So जो thickness है, whatever is the thickness of the tissue, I will go X distance from the free edge. Okay. Now since I have taken X distance from the free edge, now what I'll do, I will apply a knot, square knot or a reef knot or a surgeon's knot of my choice. I'll apply and then I cut the suture. Now since I have cut the suture, this will be an interrupted suture technique. The same suture is not going to run. You have cut the suture. So this is interrupted suture technique now, first of all. Now what I'll do, he's saying that when we apply sutures, there is a gap. So the next suture I'll apply from this suture at twice X distance. Is suture say twice X distance? Twice X. What is X? The thickness of the tissue which I am approximating. But X distance again from the free edge. Okay? I'll enter X distance, out, in, out. So I'll again apply a knot. Right? So now I'll cut it again. So I have two sutures applied. Likewise, the next suture also will be at a 2x distance from this suture. So between the distance between the two sutures is twice the distance, the thickness of the tissue I am approximating. But the distance of the suture from the free edge is the same, whatever is the thickness of the tissue. Whatever is the thickness of the tissue, I will take that much distance from the free edge and apply suture and tie the knot and cut it. The next suture I'll take twice x distance from this suture, but x distance again from the free edge. Understood, everyone? Understood? So this was a simple suture technique which you commonly are going to do when you're in your internship in casualty, right? Then we have this x to x. This is called x to x rule. X to x rule. This x to x rule we will only follow in a simple interrupted technique, not in mattress. Now what we do in mattress? See here. Just try to visualize it. What I'm going to do, I will insert a needle in a, I'm talking about a vertical mattress. The edges are not clean edges, the sharp edges. So I have a problem in alignment. If I do a simple closure in a sharp edges, the simple closure will bring the two edges in a good alignment. But since the edges are irregular, I will be using a vertical mattress. The edges of the two edges are not sharp, they are irregular. So to get a good approximation for better cosmetic result, I will use a vertical mattress. So what I'll do, I will insert a needle out, in. I've gone in, out. Now this is a needle. I've come out. Again, अगर simple होता, तो I would have applied a knot and cut it. But I will not do this because it's not a simple. It's a vertical matter. So what I'll do, I will rotate this needle up now, right, and hold the free edge of the tissue with forceps, and the topmost point of the free edge, I will enter out, in. Again, opposite side I'll hold, in, out. The topmost point, vertically. So what I have done, I have the irregular edge which was there, I have sutured with a suture and brought that into a alignment. This is called vertical lines. Out, in, out. Now I'll rotate this needle, hold the free edge, in, out. Sorry, out, in, out. The topmost part of the free edge. From there, I will enter the suture, out, in, out. So, this is, imagine, this is the tissue I am approximating. Okay, these are the two edges. What I'll do, I will insert a needle from out, in, right? This part, now the needle is inside, in, out. Now what I'll do, I'll hold this tissue here, the topmost point of this tissue, the edge, out, in. Topmost point, in, out. समझ आ गया? This is a vertical mattress. This is a vertical mattress. Okay. ठीक है? This is a vertical mattress. Then this is a horizontal mattress. अब horizontal mattress में क्या करूँगा मैं? Horizontal mattress I will apply in a edematous tissue. What I'll do? Out, in, out. अब मैं out आ गया. Vertical में मैं vertical जा रहा था. Now I'll go horizontally. Out, in, out. तो मतलब if this is the skin, imagine this What type of suture? Vertical mattress. And what will be this? Horizontal mattress. समझ आ गया? ठीक है? Everyone. Bouncer तो नहीं था? पक्का? So this is all for today. Come on.